So when you have a rotator cuff tear, how do you treat that? Do you rehab it? Do you operate on it? Is there different grades and you decide how to treat depending on what it is?
Absolutely, it depends. So the first thing I ask any patient that comes in, I don't even ask them, I look at their ID number and I work out how old they are.
Okay.
And then I ask them which hand is dominant,
Yeah.
and I ask them what they do for a living, and I ask them what are their activities, what are their sports, what are their functional requirements. And that gets the ball rolling. So if you've got, and no offense to anybody, but if you've got an old duck who's sitting around drinking tea and eating toast all day, and she comes in with a rotator cuff tear, we're going to treat her symptomatically and try and alleviate some of her pain.
Okay.
As opposed to the 45-year-old weekend warrior who decided to go play some action cricket and started getting some pain, and he throws a ball violently and has a loud snapping noise, and turns out he's actually traumatically ruptured his rotator cuff. So in the latter case, that guy is best off having surgery.
Okay.
The old duck,
Not so much.
she doesn't need, and let's understand that there's rotator cuff tears is a spectrum
Yeah.
from the degenerative tear in the little old lady, and she can still lift her arm up because her deltoid's compensated,
Yeah.
as opposed to the younger individual who has a relatively traumatic tear, comes in with a completely flail arm and pain inhibition.
Yeah.
And if you don't get and repair that function doesn't return. But the little old lady, she's adapted and she's quite comfortable and she can do all of the activities.
Yeah.
So not all rotator cuff tears are the same, and you have to consider the individual and their circumstances and what are their expectations, and what's their ability to get through and do any sort of rehab.
Because that's important. You can't just
It's
have the
vital.
surgery
Yeah.
and expect it to be 100%
So
after.
I typically tell the patients, the surgery is Mickey Mouse.
Okay.
We make 3 little holes around the shoulder, we do everything through a little scope. It takes us an hour, and you're in your sling.
For 6 weeks,
You're in
yeah?
your sling for 6 weeks. Everybody pretty much after a rotator cuff repair goes in the sling for 6 weeks. If we found that it's a small tear, or if there's very good quality tendon and we had a very, very good watertight repair, then I will let them start moving passively under the guidance of the physiotherapists after 2 weeks or 3 weeks. And they do a very passive assisted movement patterns. And it's just really just to keep the shoulder mobile.
Yeah.
If it's a dodgy cuff, if we're not so happy with the repair, if the quality of the tissue is poor, we will keep them in a sling for 6 weeks. They can take it off to wash and to dress. And then at 6 weeks, we know that tendon is healed roughly about 30%. And you need 30% of your rotator cuff strength to do activities of daily living, to wash, to dress, to pick up your tea, to certainly to drive. You need 30% strength.
Okay.
So if you do more than 30%, then you risk the repair and you risk the healing.
Yes.
So the stress is 6 weeks, 30%. We know if you double that, you go to 12 weeks, you're sitting at about 60%, 65%. And most of our activities do not require more than 65, 70% strength of the rotator cuff. Only if you're doing something really ballistic or you're pushing heavy weights at the gym, throwing very far, you need more than 70%. So 70-75% is about 14 weeks, and this is whether you're a 65-year-old diabetic or this is whether you're a 35-year-old rugby player. These tendons take 3.5 months to heal. So in our rehab process, 6 weeks in a sling. By the time you come out of your sling, you're stiff.
Yeah.
So until about week 10, it's all just about getting range of motion. And when you've got good range of motion, which I classify as at least 80% of the opposite arm, if the opposite arm is normal, then we start a strengthening protocol and gently start just with some resistant isometrics and eventually progressing onto eccentric exercises. And then ultimately you're going for the functional stuff, the integrating the whole kinetic chain
Yes.
getting back to balance and posture.
So overall, if you're a sportsman, you've had your operation. We're looking at about 4
4
to
months.
5 months maximum to get back into contact.
Certainly no return to pre-injury or pre-incident activities for 4 months. If you're involved in a ballistic activity, if you're involved in any contact, although contact is more relevant to the instabilities, but certainly 4 months before you can do any resisted efforts onto the shoulder.
Okay, great. Talk to us about platelet injections, PRP. Do you do them for cuff tears, and how do you do them if you do them?
Okay, so it's a bit of a minefield because there's all the evidence is anecdotal.
Okay.
There is some evidence looking at the randomized trials, looking at PRP versus just plain saline injections, and the results are inconclusive.
Okay.
That the best evidence is just anecdotal. So if somebody says, I've had a platelet injection in my ankle ligaments and it worked really well for me, I want to try it, maybe the placebo effect of having the platelets injected. We know from a lot of work done intraoperatively with platelet enhancement of rotator cuff repairs, it hasn't made any statistically significant difference.
Okay.
So in rotator cuff issues, I don't think that it works. And the reason for that is you've got a broad, flat tendon, which is relatively avascular,
Yes.
as opposed to a tendon that's got a nice tendon sheath. And if you can get platelets and a healing blood vessel stimulating effect in that tendon sheath, I think that you can help that tendon sheath. Because you're not going to inject the tendon.
Yeah.
If you put it into the shoulder, especially if you put it into the subacromial bursa, you're just going to cause a lot more beefy redness, more synovitis, and those patients are often worse off.
Yeah.
So I use platelets rarely for people that have arthritis of their shoulder,
Okay.
into their shoulder joint, but I've had no success with treating patients with rotator cuff pathology or impingement with platelets.
Okay.
And cortisone,
Yes, that was my next
yeah, so
question.
cortisone I will use in the old duck who's sore,
Yeah, for pain management.
but she doesn't ever consider a surgical repair.
Okay.
Cortisone is a very strong catabolic agent, so it breaks down tissue. So if you have inflammation, inflammatory tissue, it'll break it down so you'll feel better.
Yes.
And then that does two things. It also breaks down your normal tissue.
Yes.
So we know that any tendons that you've injected cortisone in or around is up to 20% weaker after a single injection, and that's long lasting. Plus then you've removed pain, you've weakened the tendon, the patient feels better, because they do feel better, so then they carry on doing their activities without actually rehabbing, without paying attention to the problem, what is causing the problem.
Yes.
So they've got a much higher chance of getting tendon tears and ongoing issues. And then if you want to go and repair that tendon, you've also suppressed that tendon's ability to heal. And so therefore, if anybody's got any intention of having surgery on their rotator cuff at any stage,
Yeah.
personally, I avoid cortisone. Some people still bang in cortisone routinely, any sore shoulder, but I've certainly seen in my practice people that have repairs and they've never had cortisone tend to do better in the long term.
Would you, in a very painful shoulder, then trying to rehab the shoulder but not getting anywhere, would you then rather recommend anti-inflammatories or something like that to just help with
No,
the
so
pain?
if there's a tear, then I stay away from cortisone.
Okay.
If there's no tear, if there's a roaring bursitis,
Yeah.
and as you say, the patient's got just a significant tendonitis and they can't actually do the rehab,
Yeah.
I do consider them not as first line. Still try and settle them down with other modalities.
Yeah.
But if they're not responding to that, yes, cortisone is an option. And I've got lots of patients that have had wonderful success. They had one cortisone injection and I've never seen them again. So they've
Yeah.
either gone somewhere else or they've improved.
Get better, yeah.
And unfortunately, that's the problem with our society, isn't it? We want an instant fix.
Yeah.
We want to just sort it out for me and let me get on with my life. But actually, the shortcut doesn't provide a long-term solution.
Okay.
And we know that rehab, for a typical rotator cuff syndrome, so somebody's got an inflammation, they've got a bit of impingement, some mechanical complications, they need a good 6 weeks of rehab, and about 70% of them will improve in those first 6 weeks. If they stop the rehab at 6 weeks, 60% of them regress. If they continue for another 6 weeks with their exercises, their stretches, their stabilizing movements, 80% of them are long-term good and stable.
Okay.
So it's not a universally this will work for you,
Yeah.
and it does require a long-term commitment.